الله. أهلا بالجميع. Welcome everyone to this evening, our evening webinar. And we are happy and glad to have with us today the team, which our friends from ICGB, and we would like to welcome Dr. Brian McEllistrem, who's a family physician in Ireland, and he's also an he's a medical educator, and he's interested and in the areas of assessment-led and promoting and improving the curriculum for JB training in Ireland. And we would like to welcome him tonight for this webinar on learning-based learning. Welcome, Dr. Brian.
Thank you.
The floor is yours.
Thank you. It's very pleasurable to be here with you.
Something went wrong. Try again.
I'm just going to share my slides now and bring them up. Okay, as Dr. Ashaya said just there, I'm a family medicine specialist practicing in Ireland on the west coast of Ireland in a place called Limerick. So the next stop is kind of New York. We're quite westerly, just in terms of kind of where I'm coming from. And I also have worked with the college for the last few years around GP training, curriculum assessment, kind of novel assessment tools and programmatic assessment. So I was asked to give you a lecture. Actually, lecture is probably the wrong word. I was asked to give you a talk on learner-based learning. And me speaking to you in this format is a little bit tricky because I mean, I don't want to just be a talking head on the screen and you looking at slides. So what we're going to do is we're going to break things up with a poll, or a few polls actually. You should have a link to an editable PDF. So this is something you can either complete on your screen in front of you or you can print off. So you could have Zoom on one side and the editable PDF on the other. And that editable PDF, that's private to you. So you can put anything you want in that that's personal or stuff you wouldn't necessarily share, because it's going to be your aid coming away from this meeting to get something practical out of it. And it's not going to be kind of a dry didactic session where you're just listening to me talk. So, so maybe if you want to read that in the meantime while we're chatting, and just remember that you'll be taking it away with you. Nobody's going to be asking for it at the end, just for you as individuals. I'm happy to, Dr. Ashish will stop me because I can't see the chat from where I am, but you'll stop me if anybody has any questions.
Yes, sure.
Thank you, yeah. We also have some question breaks built into it, so I'm quite happy to be interrupted at any slide, any point, and we can kind of aggregate them into sections too. So the time for the first poll. Let me just get you the question into the chat now, and we can fill this out in your own time. So let's go here now. Got to chat. Sorry, let's change this for a moment. There's the chat. So the first question is really, what are your aims for this evening? What do you want to get out of this meeting, and what are your challenges to your aims? So when I look at the results, I won't be able to see anybody's name beside them, but just come in as anonymous results. So feel free to be quite frank in that, in terms of what you want to get out of this evening and what the kind of challenges you foresee to that could be. And also, I think it would be a good idea to put it into the editable PDF. So if you can put that into the PDF for yourself, because that way you can take it away with yourself and kind of look at it later and consider it. Okay, I'm a great believer in practicality, as much as one can be. So this evening, we're not going to look at kind of concepts around medical education. We're going to look at kind of practical tips. So if you want to kind of stop me or kind of explore some of the things we're going about, we can certainly go into more detail in the background in terms of where the evidence comes from and why we do it such a way. But for the most part, we're going to stick with the practical tips that we can get that we'll find useful day to day. So firstly, let's define, as is always a good idea, what learner-based learning is. So it's known as a few things: learner-centered learning, student-centered learning, and really they all kind of come back to the same two concepts. So it's a concept of social learning and experiential learning. Now, some of you might have heard of Vygotsky. He's a Russian from about just over 100 years ago. We looked at the concept of social learning and how we interact with our peers around us to actually learn more than we could as an individual. And we'll come back to Vygotsky later. It's a really interesting concept when you start to tease it out. And then that other diagram on the right is Kolb's kind of experiential learning. So having the experience, reflecting upon it, conceptualizing around it, and experimentation around it again. So they're the kind of two main topics. And some of you might be familiar with Kolb's or Vygotsky already. They're quite prominent medical education theories. So that's the first thing to say, really, that learner-based learning is around those two main topics. And we'll kind of tease them out a little bit more as we go along now. Okay, just give me a moment now. I'm going to stop sharing here and I'm going to bring up our poll result and see what you want to get from this evening and okay, now. So I might just read them out, actually, probably is the easiest thing to do. So our responses for what your aims would be. So to be professional in their specialty would be kind of one of the main concepts to see coming across in topics. And the challenges to your aims are to keep updated, so to keep contemporaneous, I guess, with your with the specialty. So I think that's good. So maybe what we might touch on now is a few more areas that I thought you might have touched on as well. So the kind of common themes that come up around this are, to be specifically better in a specific area in the practice of medicine. So, cardiovascular, renal, etc. You could take a more holistic view, and you could say you want to be a better doctor. You might have a different role where your time is spent more away from being a clinician and more administrator. And you might have kind of concepts about being a better team leader. You could be a trainee at the moment and you want to pass your exams and get on with your career. It's always a very, a very pertinent thing to do. And it could also be things for like career advancement. Perhaps you are working in, one area and you want to progress to another area and you want to address your needs to do that. So generally the challenges then, the barriers that we meet on the way to these aims, time will come up every time. It's always the case that when you talk to clinicians and you talk to them about medical education or their own education, the balance is between delivering a service and making time to train those who deliver the service. And this is universal. Like this is in North America, Europe, Middle East, Far East. Everybody has this issue. I think there are some other kind of latent things that people don't talk about as much. I mean, it's a fear of failure. I mean, if it's difficult when you're training and you're always being trained to be an independent practitioner, to admit that, well, I need to revisit this, and it takes a mature learner to do that. I think, to say that I don't feel fully competent to this, to the needs around me. And again, just touching on this is the idea of kind of professional standing. So this is the case worldwide. Again, like you are working, particularly as you become more senior, it becomes more difficult to admit sometimes that you actually do need to revisit a topic, or maybe something new has come along. Like a lot of stuff around, off the top of my head, anticoagulants, for example, in the last few years, and antiplatelet agents. That's all be coming through quite topically, and it kind of does change the management a lot for patients. And finally, it's professional isolation. Now we're going to talk about communities of practice concept again, other people might have met with. But sometimes you could be surrounded by people, but professionally you're isolated because you find it difficult to have a rapport with anybody. And it's very difficult when you don't have peers that are similar to yourself to lean on, to work with colleagues. That can be quite a barrier. Okay, so I like to know where you start, where you're going. So what is competence? So competence is a term you'll hear of regularly in medical education. It can be defined in loads of ways. I mean, we're not going to get into them all this evening, but just to touch briefly on the kind of diagrams at the top, you might have heard of unconscious incompetence all the way up to unconscious competence and become the ways between it. Miller's pyramid is kind of, universal. A lot of people know about that. There's the cruise and cruise model on the right, which is seen as an improvement, and Miller's by some because it kind of improves on professional aspects or professional kind of considerations beyond just does, so far as is the person they should be. And then there's other definitions. So what is competence? So the broad definition would be the sorry, the Kennedy definition would be, it would be knowledge and skills, be conscientious. And this is the idea of conscientiousness and thoroughness and dependability is we're going to touch on a lot later. Discernment too, I think, is another huge issue because, you know, you have to be self-critical, I think, truthfully, to know where you stand and where you're going. And then finally, it's truthfulness. And I think truthfulness can be taken in many ways, especially towards yourself and what you're up to. So this is a competence on the y-axis versus time on the x-axis chart. And this is something that I think we'll all be fairly familiar with, that with time, one would expect generally, not always, but one would expect generally that their competence improves. They'll become more competent with time. And that's what we're all aspiring to, both in training and as specialists. And there's various points along this trajectory. And we're going to see later how this all ties together. But you could say that I'm at the start of the curve, or maybe I'm at the end of the curve where I'm more looking for a refinement, as opposed to the start where you're looking for kind of, you know, data digestion, basically, and getting knowledge up on board. So the next question for you now, which I'm going to put into the chat once I read it out. So you as an individual, and remember this is all anonymized, I won't be able to see the responses at my end. What point do you think you're at? And when I say what you're at, you can pick whatever competence you want. And what are you hoping to achieve? Where are you hoping to move along the trajectory? And finally, is there anything missing from the above? Anything that I might have intentionally missed out that we can talk about later? So something to think about. And then in your PDF, the one that you can edit and save, just write down what you think your own competencies are. And these need to be quite specific. Some of you might have heard of the SMART acronym for kind of goals and learning outcomes, but I mean, be quite specific about that. So that could be, well, I need to deliver a diabetic service in the clinic. I need to look at my rheumatoid knowledge. I need to look at my diabetic knowledge. So, you know, be quite specific with yourself, because that's private to you. You don't have to share that with us at all. So just give me one moment. I'll give you the link for that now. Now, that should have dropped into the chat there. So I might just give you a moment to go in and look at that, because I think you know, you're going to get more out of this talk if you start to really consider it from your own perspective. So we might just give it a quick moment and let people click into that. Okay. And while you're kind of filling out your PDF and indicating where you are and where you want to be, and also if I missed anything from the above, I'll just move on a little bit here. So the assumption, I think, would be fair to say that we all aspire that with time we become more competent, we become better doctors. I don't think anybody is looking to do anything but that really with their time. And at this point, I'd like to introduce a kind of fictional trainee into the picture. This is going to be Fatima. And for the rest of the slides, or for many of the slides to come, we're going to look at Fatima's kind of learning journey and how that can be facilitated in certain ways and how it's best done. But again, Fatima is just an illustration, and if you took this talk just to relate to Fatima, there's really no applicability to your own learning needs. So I'd encourage you to fill out the PDF as we go along and take that with you once you finish up the session. So for the purposes of this talk, we're going to say that Fatima is on the lower end of competence, but also on the lower end of time. So we're starting off some on the left in both respects. Okay, let's have a little quick look at our polls and see what people came up there. Oh. Okay, I might actually share a screen with you here. That's the easiest way of doing it. Okay, so for the first question, what point are you at? I think we had 4 responses, and most people kind of saw themselves either being at this very start or slightly into the curve. And moving towards the end, then everybody wanted mostly to be at the end of the competence curve. So that's an important concept, something we're going to touch on later, and we're going to see how how that might relate. And I think there was no identified pretext missing bits from the other end of it. Okay, so we'll go back to our slideshow and we'll work through with Fatima and see where we can get with Fatima. Okay, so as I had mentioned earlier, we kind of have to ask ourselves, if we were Fatima, where are we at the moment? I mean, what kind of learner am I? How do I learn? And how do I find out where I'm starting from? So these are kind of core concepts, because if you don't know those, it's trickier to build on it, as I see. And this comes back to, let's touch a little bit on literature here, and theory, the kind of concept around what type of learner people are. So when we're children, we learn, I guess, as children do, and as we move towards being adults, we learn differently. So generally, how this might kind of come into medical education would be that those at the beginning of training might be kind of more along the pedagogy kind of descriptor of things, where they're being more instructed how to do things. They're more receiving information as opposed to seeking it out. Andragogy is probably the next way of describing it in terms of maturity. That's where you have adult learning kind of generally is described as andragogy and heutagogy, which we're touching on in a minute. And in andragogy, you have somebody who has a problem generally, and they have a problem that's their problem, and they need to equip themselves with the knowledge to get through it, with a little bit of support from others, and a little bit of, well, I guess there's always support, but the difference with andragogy is that you're less reliant than you are in pedagogy to being told what to do. You more proactively go out, you seek out your own learning needs, and then you find resources and ways of addressing them, basically. And then finally, there's heutagogy. And so heutagogy is really where we should be as independent practitioners, as specialists. When I say independent, I do mean that we do, of course, work as part of teams. But heutagogy is a new level again, though. So this is really somebody who is proactive. They will find the learning needs they need and will seek out the people and the learning experiences to suit that. And that's kind of more the person, so on this kind of arbitrary scale here, not the person who's learning physiology, nor the person who's learning physical exam. This is the person who's been tasked with, changing the department, delivering a new service such as diabetic care, rheumatology care. And that is something that's unique to them insofar as they have generally a kind of a local context. They have to learn, they have to situate themselves in, and they have to find solutions that suit the local context. So they can't really rely on anybody to tell them what they should do, because there is nobody who possibly would be able to know exactly everything they know. So it's a different aspect. So this is what heutagogy is, and this is what I would advise you would view yourselves as somebody aspiring to be. So another way of looking at heutagogy, I don't know if anybody follows Formula One, the motorsport, but this is Lewis Hamilton in his Patronus Formula One car, the Mercedes AMG car. And if anybody does know anything about Lewis and the team, they've had phenomenal success in recent years. They've had 7 World Championships. He's competing with Max at the moment for an 8th. And I mean, really, how I would view the reason why I'm showing you a picture of Formula One is not just to tell you I like Formula One, which is true, but just think of yourself as a Formula One team. So you can imagine, I'm just going to give you by way of a bit of background. The Formula One teams are constrained by rules and regulations. This front wing can only be a certain shape. This thing can only be so on and so forth. But they strive independently to improve themselves continuously. So they're self-determined. They're looking for the next gap. They're looking for the next improvement, that little, as they say in Formula One, that little bit of delta, a little bit of difference that can improve them. And this isn't a competition with your peers, but we're in competition with pathology and competition with a moving, learning kind of feast in front of us. And what heutagogy really goes back to is autonomy. So your self-regulated learning, your capacity first, so you're seeking it out, and your capability to do it as well. So you're combining all those together independently to seek things out. So I want to touch on Lewis Hamilton and really not just Lewis, but really the team around him, because it's really multifaceted, and that's how I think that's how everything in life has to be. As I say to my wife says to me, you have to look for the deltas in life, the little 1%, and there's a school of thought out there about 1%, and that if you can just make small 1% improvements on a regular basis, you'll be much further from where you started very quickly. So I might just take a quick break now, or a moment, should I say, not a break, to take any questions that have arisen from the group or from the chat. Any chat? Quick look here. Okay, I can't see any questions. Does anybody want to unmute themselves and jump in at that point? No? Okay, we'll keep going, so I will have it in the next section. Okay, so I hope you enjoy this next bit. This is going to be looking at the Johari window. You might know it's called the Johari window, but I suspect a lot of you will have seen this diagram already. For those of you who don't, the Johari window came about in the 50s, primarily looking at really team management and identifying kind of relationships, I guess the best way to describe it. It's a 2x2 matrix defined on two different axes by the what you know, so known to yourself, not known to yourself, and what other people know. And this is quite a nice concept because it lets you tease out things quite appropriately. So starting at the top left, what I know to myself and what's known to others is known as the arena. What's known to myself but not known to others is known as the facade. What's not known to myself but known to others is the blind spot. And then there's the quite famous concept of the unknown unknowns, which is the not known to others and not known to myself. So we're going to touch on all parts of this in a kind of pragmatic and hopefully practical way for yourselves. But I'd ask you maybe at the moment to consider that. So what do you know about yourself that others don't know, and vice versa? What do you know about others? What do you know about others that you feel that they might not know? So that might be things like specific medical management, or it could be things more holistically like team management, way they manage themselves professionally, or that kind of way. So take a moment now, if you would, into your editable PDF and describe your arena and your facade. So the arena is what you know to yourself and is known to others, and the facade is known to yourself but not known to others. And again, this, for those of you who joined us in the last few minutes, last little while, this PDF is completely private to yourself, and you don't have to share it. And so you want to, everything you put down there is just for yourself to be taken away from the meeting this evening. So I'll just, whilst you're thinking about the facade and the arena, what I might do is I might introduce Fatima again. And you can probably make this more relevant to yourselves. So let's say Fatima has thought about this, and it's not something you do quickly, I guess, ideally, but she kind of admits that she's quite maybe doesn't understand about cardiovascular risk management, and others aren't really aware of that. But she thinks that she's quite strong at rheumatology, and that would be kind of generally agreed amongst her peers. So for her, I guess, her self-identified learning needs, and we're going to discuss learning needs outside of self-identification later, but the one that she's been able to pick up is cardiovascular risk management. So again, just if you want to take a moment to consider what your facade would be in terms of what you would like to address in the coming future in your PDF. And then, so that's your self-assessment, but the other kind of key concept, and one I touched on earlier around communities of learning and social learning, going back 100 years to Vygotsky, is the blind spot. So what do others know about you that you don't know about? And this can be quite a tricky one to elucidate, because how do you get feedback from others sometimes? It's not as easy as it sounds on paper. So let's have a look at that all together. So communities of practice. So what are communities of practice, and why are they at all important? Why are we bothering to think about them this evening? Communities of practice are groups of practice defined by the service you deliver, the service you're learning about, the service you're keeping up your competence in. So that's, that could be your peers, your medical peers. It could be your allied health professionals you work with. It could be educationists you work with, your co-trainees. Generally a community is defined by a group that has a common goal. They're all working towards something quite defined. So how does that look in real life? Let's bring this back to practical, because I think we've had a lot of theory now. Let's We'll wake ourselves up with some practical thoughts. So our toolkit. So it's WhatsApp groups. I don't know if any of you are part of WhatsApp groups, but I'm a member of several. I've a local CME or continuous medical education group that posts on it regularly. I'm part of a trainee group that my colleagues I trained with years ago. We still keep in touch regularly. We're going to talk a little bit about feedback actually, because I feel quite comfortable in those groups because I know they're peer groups that I can work with. Other common ones would be kind of instant messaging software used in the practice. A lot of the software suites in Ireland or separate suites of IT implementations allow for instant messaging where you can quickly check things with colleagues, quickly check things with the administration staff, nursing staff, and that is a community of practice. So that is a fantastic learning opportunity because oftentimes, whilst we might be responsible for our nursing and administrative staff, they have day-to-day experience and things, they're seeing things happen and they can give us invaluable insight that can help our overall competence ourselves. And finally, coffee breaks, which were superb before COVID, but hopefully we'll be back again. So sitting down, for example, if you were a trainee working in the hospitals and you've just done the morning ward round, you've seen all the patients that came in the last 24 hours and on the call, you can sit down, you can tease things apart at that coffee. And these are the kind of this is where our communities of practice are, and these are invaluable. Nothing like, don't take them for granted when you're a trainee, because when you move on, professional isolation does start to seep in sometimes, and you have to work to avoid that. So when you have them readily available to you, take full advantage, be frank with your colleagues and seek their advice on what they might know about you that you don't know about yourself. So that's your kind of your blind spot, as they call it, your Harry window. Okay, so we're going back to our competence versus time curve. So the competence is somewhere down here, we think. We want to move it up. How do we go about that? So by doing the process we just did there, and you can do with your PDF, with our facade and our arena and our blind spot, we know exactly where we are. Sorry, we should know, Fatima knows exactly where she is. This is our point, and that's perfect, because now we can build on that. Now we have somewhere to go, as opposed to not knowing where we're starting. So another brief touch on the literature. Scaffolding is a lovely term, and some of you might recognize that animation from a well-known show. But scaffolding is just as the animation describes. It's the support around you whilst you're learning. And it's often described in parallel with what's known as the proximal zone of development. Now, the proximal zone of development, in a nutshell, is this diagram here. So this is what you are, this is where you are at the moment. This is where you can move to, and this is where you will move to eventually, or cannot do it right now. And the key behind proximal zone of development and scaffolding and communities of practice is that you were brought through your development of learning by your peers around you. And that's why the WhatsApp group, the coffee, the instant messaging are so important. So the more experienced of you who've been around for a while will probably know a lot of this already. But maybe some things are new here to you in terms of how we can learn and identify our own needs. So Fatima, if we remember back earlier, was quite good at rheumatology, but she wasn't so great around cardiovascular risk management. So Fatima's a trainee. She has many learning experiences, uniquely available to her as trainees do. And she has decided that the best way to address this is to go to the cardiology clinic and expose herself to the use of kind of decision-making tools, the factors that are associated with same, and just upskill to the appropriate point. So now that Fatima is going to the cardiovascular clinic, or you would be wherever you have identified in your personal and private PDFs, she wants to move information from the blind spot into stuff she knows about herself, as well as people know about herself. So she wants to minimize this and maximize this. But there's a problem here. And this is a problem that we've proven in the college through research recently published, is that often people, and generally your trainer or your peers, when they give feedback, now this particular study was looking at trainers, when they give feedback to you as the trainer, learner, kind of interchangeable in the scenario, they feel that they're giving good feedback about 90% of the time. But the learner or the trainee who's taking the feedback on board only picks up on it about 44% of the time. So suddenly we're bottlenecking our ability to learn from our peers. And that's terrible in my opinion, because I mean, really, if you look at the leading individuals in, You could look at Toto Wolff in the Formula One, going back to the Formula One. You look at the team bosses there. You look at the industry of technology, the Steve Jobs of our day, rest in peace, and the rest. They are fantastic because they're holistically looking at the round. They're not kind of bottlenecking themselves. So we have to be appreciative of the fact that it's difficult sometimes to get the feedback and to actually listen to know what's going on. So what's good feedback practice? So this is kind of a sub-segment of what that arrow is in terms of how we can get the feedback. And I think it's quite good to name this out because it, there's some topics in here I think a lot of people relate to. So let's go through for Fatima. So Fatima knows where she is. Now she has to seek the information to where she's going to become competent, the performance expert. She needs to get this feedback from multiple different forces where we've touched on that. We have communities of practice where we can talk to our colleagues and our peers and also more formal mechanisms. And for you involved in training, you have access to the Canvas, the AHEED platform to allow you to access your feedback regularly and kind of build up a rich picture around it. And she, as we said earlier, and Johari, she has to make decisions about her capacities. So feedback is really a kind of conversation between her and her trainer or her person who's giving us feedback. So it's not all one directional from the trainer to her in terms of what she can do. I think it's fair enough to say that she would have an input into what's being discussed. And there has to be habits of continuously seeking these feedback events. And this is the one slide I really like. So manage the emotion. So whilst you have to be proactive in seeking the feedback, you have to appropriately take it on board when you get it. So if you're becoming defensive, it happens. I think we all do it when we're caught out, I guess is the colloquial way of describing it in Ireland, when we are less than competent in something we thought we were. And that can bring on defensiveness. And defensiveness really isn't productive. But we have to, and it's easy for me to say that here, but it's not as easy in real life to address. So I think when we're seeking feedback, we have to think about the possibility that maybe an emotional response will be elicited in us when we get it. And finally, you have to take action. So I guess as adult learners, as you're saying with the Mercedes Petronas team at Formula One, when they identify performance upgrade, when you identify a better way, more efficient way of learning, you're going to do it. Of course you are, because your time is precious. We've established that from the get-go. And that's what we've done in the college in Ireland as well. We've developed feedback tools that have built-in kind of action plans as part of them, and then we published them that late last year. Okay, so great. We're making progress now. So Fatima is coming up along. She was here and she had lower competence. Now she's becoming more competent, and then she'll have to start making decisions now soon about how she wants to learn and the best way to address her learning needs. So just before I go on, and just because we covered a good bit of topic there, let's give a chance for anybody to unmute themselves and come in if they wish to. I don't believe there's any questions in the chat. No questions? Okay, no trouble. We'll have time at the end in any case. So this is the cruise and cruise model we touched on earlier. You might be familiar with it. You're starting off your nose, how, shows how, does, and then cruise and cruise being improvement over the original Miller is. So the person's kind of inclusive of professional attributes of the individual. So for Fatima to improve, there's various ways of doing that with different trajectories. Some of them are less efficient. Some of them are kind of averaging efficiency, and some are highly efficient. So some things are really going to get her to learn quickly. So I don't know if anybody's involved or has a pastime of DIY. It's one of my pastimes, apart from watching Formula One on the TV. And if anybody has been confronted with a rusty bolt that they have to remove, there's various ways of removing a bolt, and there's various ways of doing it. You could use the vice grips, as we call them in Ireland, on top of the image there, or you could use a spanner. And if you have ever tried to remove a rusty bolt, you know exactly which tool you want to use, and you wouldn't touch the other one in the month of Sundays because you'd be there all day. So we're going to go back to this idea of tool picking, and this is known as constructive alignment in medical education. So what you're trying to do is you're trying to expose yourself to learning opportunities that align with the overall picture of what you want to learn. So it's kind of like getting back to our scaffolding idea. First, you build you build your foundation, then your scaffolding, and move on from there. So, if any of you want to learn a skill, let's say it was aspirating an E-joint, would you go to the textbooks to read about it? Would you watch a video maybe on YouTube? Would you go to the simulation lab? So there, let's just say that those are 3 options available. So somebody has asked you to deliver a new service, something that you're not competent right now, and you want to become competent in it, and you have various modes in front of you to kind of get the confidence in that. So that's the really key concept in medical education. It's all about the right tool for that rusty nut. How do you make the best use of your time, and how do you learn? So what I'm going to do now is I'm going to introduce another poll into the chat, and we're going to see what you would think. So what tool would you pick for learning how to aspirate a knee? I'll just pop that in there so it should be visible to everybody. So you can take a moment. It's just a simple question. Which of the 3 would you like to use? Okay, so let's go back to the slides and consider it for Fatima. It's the spanner, by the way. Just I presume anybody who's tried to do it would know, but a spanner is much easier for rusty nut. And that's what Fatima wants to do. She wants to take the most efficient curve, and we're going to look at the poll results in a moment. So if you could have a look at that in the meantime and populate that. And again, as you saw earlier, it's all anonymous. Fatima wants to take the high curve. She wants to maximize her efficiency and learn as best she can, as most appropriately in the time as she can do. Okay, so let's jump back over and we'll have a look at the poll and see what everybody thought. And oh, actually, would you put that up to I'm just going to go back to the second question too, because more results came in. So maybe there might be a slight delay with Google, but I think we can see there that a lot of people are at, what are we at? The majority of people are at B at the curve, some people at the very start, some people a bit further up. And the same results probably didn't really change much. Everybody wants to be high level of competence or very high competence. Okay, so let's have a look at the question. So our question was, which are the best learning tools for learning an e-aspiration? Which one would you pick? So you have 3 options: textbooks, the video, or the simulation lab. Oh, I think I'm in just there. It's quite chatting that one.
Actually, it was not received in the chat. Maybe it was repeated
of
the previous one.
Apologies. Oh, yeah. Sorry. Let me just get it again for you.
Yeah.
So that's poll 3 just dropped in again there. Please came through that time. Did it work that time? Can you can everybody see that poll there? Just give you a moment to do it there and see.
No, actually, I think it's not there.
God, not the right one. Sorry now, guys, about this. Let's have a look and see. Oh, you're very right. You're very right. That's the same one as previous. Sorry about this now. 2 moments. Yeah, this is a better one for you. No, that's a better link. Okay, so let's just take a moment to have a think about that. So we'll do it together because we have a moment. So the question would be, if you were learning to aspirate a knee, would you choose to look at it in terms of textbooks, video, or simulation lab? And this, I guess this question is unique to yourself. So what would you feel the most appropriate to? Okay, okay, I thought there were responses coming in. Sorry about that duplication video. Okay, so great. People are quite picking up this quite quickly. So we have simulation lab.
There is agreement.
There's agreement, definitely concurrent on that point. Okay, great. Let's go back to the slide so I'll tease that out a bit more. Okay, so what would you choose? So being facetious a little bit, it actually doesn't matter what you choose. for this audience, yes, the simulation lab is probably the most appropriate for this audience. That's what we saw reflected in the results. But you can imagine, going back to our earlier models of learning, you can't really aspirate a knee if you don't know what the knee anatomy is. So maybe you do need to go back to the textbooks, like electronic learning aids, text-based ones, learn the anatomy of it, and you graduate up through it. And this, just touching back on an earlier concept, kind of goes back to the idea of proximal zone of development. So as you are building your building here, you're putting up your scaffolding, so you're learning your textbook, then your videos, then your simulation lab, and then the building follows. So it's all building on what was there before. And that's really a key concept for that PDF that you're bringing away with you this evening. That's unique to you and where you are and what you want to do. So you need to build the steps behind that, be the Formula One team, look for the kind of the deltas, as they call them, in terms of how you can improve it. So let's move forward. Oh yeah, I really have to touch on code cycle because it's such a, I guess, a core consideration. So this is code cycle. It's known as the experiential kind of model. So you have an experience. So in that previous example, it might be the the patient presenting with a painful effusion of the knee, an acute presentation. And then on the day, you might deal with it a different way. You might ask a colleague to help with you, or just manage it through the various means you have in front of you. But when you go away from that situation and you're thinking about that evening, the coming days, the coming weeks, you're probably going to ask yourself, I wonder what the best way of dealing with that would have been. And you're probably going to look into that. And then you're going to come to the thinking phase and say, well, I think really what I would have liked to be able to do would have been to aspirate that knee. So I can get a sample, I can look for cell counts, I can look for crystals, I can get a very quick idea of what's going on, not to mention it being therapeutic to the patient at that moment. And then you go back to acting. So that depends on your level of experience. You might proceed directly to a clinical procedure with supervision. You might go back to the sim lab. And this is this concept, again, getting back to the Formula One, you might be changing the front wing and you're putting it through the wind tunnel and you're just looking for that little bit of improvement in yourself and moving it through the process.
Dr. Brian, there was a request in the chat that they would like to increase the volume of your... Actually, yeah. I'm hearing you well, but maybe someone is having an issue about this.
Can you? Yeah, I'll try and speak a bit louder. Yeah, I don't know.
Yeah. Yes.
Audio settings. Let me just see if I can make it a bit louder here. Microphone. I'm going to turn it right up.
And there is a request that we should have the options to choose multiple choices. More than one. Okay, maybe in the
You're right. You're perfect. I can't actually just adjust volume up, so I will speak louder.
Maybe. Yeah. Okay. Thank you.
But you're dead right. That's exactly what we went on to say. You should be able to adjust. You should be able to choose multiple options because it's completely dependent on what you're doing at the time. And as it just happened, we went on to quick questions and answers. So I'm glad we had this interlude. Yeah. Now, so let's move on to the next section. Oh wait, sorry, the Zoom is fighting with me here. Just have to come out and go back in. Okay, so a key consideration is competence versus time. So Fatima has done great work. She's gone to her cardiovascular clinic. We've looked at the knee aspiration, and she's improving competence. And let's say she's got to the stage where she's actually appropriate for her level, or her level as an independent practitioner. She's now a family medicine specialist. She's passed her exam. She's received certification, and that's all been arranged. And that's kind of denoted in this chart by the yellow line. So she's above the yellow line. She's an independently practicing FMS. Let's say she wants to go a bit further and she actually wants to either become, like say, develop a special interest in the aspiration or cardiovascular risk, or she wants to be responsible for a larger group of clinicians around that area. So perhaps she wants to go even more competent above the green line. But the key problem is kind of Freudian slip, but the key thing with competence is it's not eternal. Once you get it, you don't keep it forever. And this is, this is something you're probably all very familiar with, is the idea of continuous medical education. So either we can forget things, or medicine can change in the background without us knowing. And that could happen with poor Fatima. So if we go out a couple of years, her competence could drop below her previous levels, and could even drop very low to the point of being below the competence of an independent practitioner. And that's a bit of a problem. Because I said earlier, medicine changes, so it might not be known to us either by the fact that nobody knows what's changed. It could be something that's slipping out of the way, and that's extremely difficult to address. But what is addressable is knowing what's out there has changed and that we haven't picked up on. So how do we, as independent, speaking to the family medicine specialist right now, how do we as practitioners make genuine and concerted efforts to ensure that we don't do this, we don't drop down? We want to keep competent, don't we? We want to stay with the area of competence. So we manage this through Heutagogy. So this concept of being self-regulating, to being autonomous, to knowing your capacity and capabilities. And the practical things that might apply for yourselves would be things like the Saudi Commission for Health Specialties, their guidelines, the Institute's guidelines, the best practice guidelines. And this is the key difference here, because that's the bit, like, nobody wants to be slipping down this competency spectrum. And this will happen almost invariably with time. Things move on in the background without us. And, we have to keep on top of things, don't we? Keep developing, as our picture here reminds us from the Formula 1 team. And this is what makes family medicine even more difficult, is that we have so many competencies. So we have to know so much about so many specialties to varying degrees of depth. And if you took a moment of time, this time could be, I don't know, a year, it could be a month. Some things you'll be getting stronger on from relatively low levels of competence. But other things that you're quite competent might just start to slip off. And that's really where you have to be, where this exercise we went through today of kind of identifying your learnings is so key, because you might find that, well, I haven't seen something to do with contraception, let's say, in a few months or a few years, and it's a very specific case around the follow-up, let's say, of specific contraceptive devices. And you might find that when the patient sits in front of you, it's actually quite difficult to manage that case because you just haven't seen it. And that is the learning needs assessment right there in front of you. Okay, so what are we in now? Just about 10 to the hour. So what I'm going to do now is I'm going to just talk on some personal tips. So these aren't the literature at all. These are things that I do personally as a family medicine specialist to look at what's the best way to spend your time. I think, at least. You might think these are less useful for you, but let's go through them. So as I mentioned there, you've been asked by the patient, so how do you identify your needs early? So you might be asked by the patient, can you do this for me, doctor? Can you provide this service? You could be asked by your colleagues in secondary care or your colleagues around you to provide a service. You might notice that your practice, as in your medical abilities, is not quite on par with your colleagues, and that happens. You just say, right, well, they might have a lot more competence in that area. Now that might be a case that they have a particular interest in the area and they go beyond that level of competence we looked at earlier, or it could be that that's just what's expected in general. And you could be ambitious. Maybe you want to deliver knee aspirations or whatever it might be as a new idea, a new service in your clinic. And the other thing to think is important is set a long-term plan. I mean, think of yourself, or I do at least, in terms of what are the kind of things that we need to do, the end product we need to get to. So as I mentioned there, what kind of practice do you want to see yourself being in? What kind of clinics do you run? What services do you provide? And then there's other kind of more generalized concepts of where do you see yourself in 5, 10, 20 years time personally? And how you assure yourself that you get there through competence, building on competence through all the mechanisms we touched earlier. Sorry, my slideshow seems to be acting up. Needs to go back in and out again. So in Ireland, we have a curriculum, and that's a kind of as curriculums do. It sets out the areas for knowledge. And what I've done for myself is I've set up Dropbox folders, a folder for every name of every chapter in the curriculum. And when I come across a pretty good guideline or something that I think I'd like to come back to, I put that PDF into the folder that mirrors the list of the curriculum. And this, I think I actually find this quite good. So I'd suggest maybe doing something like this yourselves. Hold on to your articles, hold on to things you think are useful. I mean, it'll always be the question of has something more relevant come out online, and that's often good to check that it has, but I can't count them on, well, up until I started doing this, I would find an article that was excellent, and then I have to go find it a few weeks later, a few months later, because I hadn't saved it. So this is a small little time-saving idea. There are some more kind of formal ideas, courses, higher diplomas, masters, PhDs. But don't overlook being pragmatic with your career in terms of employment, specifically seeking out a job to get experience in that job. And do seek out the people who you think are leaders in your area of competence that you're seeking. So if you have somebody who's, let's say, going back to the rheumatology idea, who's very good in that area, generally people are extremely happy in medicine to pass on knowledge and pass on skills. So reach out to them and ask them for help. It'll be usually very good to do so. And we touched on the idea of document retention and organization there. And if anybody's ever doing any academic work, as I've learned over the last many years, use Mendeley or a similar kind of reference manager. It'll make your life an awful lot easier. Let's come to the end. Okay, I think we're just coming up in the hour now. So what we're going to just recap and open up to any questions. Remember competence versus time. So you're always wanting to move up the scale. I think we all agree with that. But remember, there's many competencies and things do slip down. Remember, competence is relevant and relative to your level. So you need to have a look at where you want to end up. And I hope you found this talk informative and that you can go away with your PDF with ideas and also a toolbox and of kind of ideas for it. And I'm quite happy to, to follow up on any general concepts around the literature at the email address below in the slides. So thank you very much. And I'll just check if there's any questions now.
Thank you so much. This is really very nice and interesting and informative, and all of us would like to be competent and updated and not to go down in the curve. And this is really something, it's not easy. But no. If you keep it, if you keep it and we keep doing this, it will be nice. There is many thanks has been written in the chat. If there is any questions from our audience, or even if anyone wants to take the mute and the comments.
Good evening. Thanks for the excellent lecture. Would you agree with me that one of the ways that we as the trainers challenge ourselves by training or engage in academic activities to train others, thinking that the best way to learn is to teach others?
Yeah, I think that's a hugely valid point, and something the trainers in Ireland would certainly mirror. Yeah, I think well, it gets back to that thing with the conversation on feedback now is thought to be best delivered as a conversation, not a kind of a one-way stream. So whilst you of course would have to upskill yourself to be a trainer, you may find you learn things from your trainee as well. So, but by inherently being a trainer, you will be exposed to new knowledge and new kind of concepts, which can be extremely informative. But yeah, I think there's an onus in all of us, and probably I guess going back to that chart we saw with the different lines in it, I do think that people who are educators probably do have to work to a little bit higher level because of the responsibility of the role.
Thank you, Doctor. If there is any other comment or participation from the group. Or in the chat.
I think the talk this evening, I guess, was a conceptual talk. I think really you'll have to take this away with yourselves and think about how it applies to you, because we have to make it personalized, don't we? So that's this is just a broad outline of kind of showing that you're not alone and there's people are out there to help you, and I guess the route's the same.
Yeah, and the PDF which has been said about the things which you would like to see, the arena and what is the zones that you want to see in the development is very nice, and I think it can be used in reality by each of us.
Yeah.
Okay, if there is no comments or questions, and I would like to thank Dr. Brian so much and for this nice and interesting and informative webinar. and that especially that in your this is the time I know that it's now it's becoming 6 at your time p.m. Thank you so much, and we wish that we also have another interesting session with you in the future.
Thank you. Hope you enjoyed that.
Thank
Happy to
you.
follow up too.
Thank
Yeah.
you.
Thank you. Bye
Thank
now.
you. Bye.
Bye-bye.
Thanks for everyone. Thanks for all attendees. Bye and see you.